Bismillahirrahmanirrahim. Thank you very much for letting me talk to this enlightened gathering here, and I am pleased to see that there is no space here. We have an opportunity to go so many places to deliver lectures, but today the hall is full and this machine is not working. I am thankful to the organizers for allowing me to speak to you or talk to you on a topic which is very, very lengthy. But to the best of my ability, I have tailored it according to today's situation. Just like a tailor who takes out appropriate length of cloth out of a thorn and makes according to the desired and required situation. I'm going to talk about the anomalies of first, second and third trimester. Sheikh Zayed I consider it as a second institution because I have stayed here for 2 years and I have learnt a lot from this institution, because at that time when I was here and learning, this was the hospital which was equipped with all the latest modalities. I'm talking about the radiology department, and that had CT scan, ultrasound, etc., 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 whatever was available at that time. And on top of that, the Inmol is situated right next to this institution, and we had an opportunity to actually feel, touch, do the radioisotope scanning also. How it is done, what is the difference. Sometimes what happens is that we receive a request for a test which is not in fact related to our field. It is in fact related to nuclear medicine. A lot of people they believe that the isotope scanning and this scanning is the same, but this is different. Isotope scans are the ones in which you infuse the radioactive material into the body and radiations come out. Whereas X-rays, the radiations go from outside, pass through the body, and on the other side they make an image. First of all, what is anomaly? It is something that it deviates from what is standard normal or expected. And what is an anomaly scan? A scan it is also known as a mid-pregnancy. And the ultrasound scan of pregnancy, which is done usually at the mid-pregnancy scan, takes close look at the baby and mother. It is to check the baby whether it is developing normally and where the placenta is. How do we divide the pregnancy? The period which is taken by the pregnancy is 40 weeks. If you calculate, it turns out to be about 9 months. And that is from first day of woman's last menstrual. What is a trimester? 3 months of pregnancy is one trimester. So the first 3 months is the first trimester, second 3 months is the second trimester, and third 3 months is the third trimester. And what I am going to talk is the anomalies which are encountered in these three. What is the duration? I have already talked to you about a preterm, the fetus which is born at or after 37 weeks is a normal term baby. But if it is born before 37 weeks, it's a preterm. And then there are two further divisions. One is the extremely preterm, in which the fetus is delivered 23 to 28 weeks. And there is a moderate preterm, which is between 29 to 33 weeks. What is the note? Although the routine anomaly scan is carried out at mid-pregnancy, certain anomalies can be diagnosed in different trimesters. So even at the last trimester, there are certain situations, conditions or deviation from the normal which help the anomaly scan in the third trimester. Usually it is done in the mid-pregnancy level. What are the fetal anomalies in the first trimester? Some major anomalies can be diagnosed, may be able to suggest structural abnormalities. And the head, fetal head, spine and face. This is concentrated, focused, and in early embryo, less than 10 weeks is best examined with TVS ultrasound. If the smaller is the fetus, it is less likely to pick up disease on transabdominal ultrasound. If you are using, if you are doing imaging for the anomaly scan, the smaller the fetus, transvaginal is the right modality to go for. By a 10 or 11 week gestation, echogenic choroid plexus fill the lateral ventricles, and ossified frontal and parietal bones. These are the head, spine and face figures. Now look at this image. This is the fourth ventricle, which is right about here, and the scan is done at 7 to 8 week gestation. This fourth ventricle is large at this stage, but as the baby grows, this becomes smaller. But if it persists, there is an abnormality, because cerebellum is formed and cerebellum takes its place. So if this is persisting, it means that there is an abnormality. These are the two choroid plexuses, which is a normal finding. Another normal finding is the two thalami, and this is the front of the head, and this is the occipital region of the head. This is the partial part of the cerebellum and so on, and the thalami are in front. If you look at the 12-week gestation scan, there are two frontal bones which are very clearly visible. There is an arrow mark, and here it is. Similarly, on 12-week scan, acrania. What is acrania? When the cranial bones are not ossified and not developed, and the brain is just a brain is there. If you compare it with this picture, it is the same axis. Frontal bones are echogenic, they are visible at 12 weeks, and here 12 weeks there is no frontal bones. What is an encephalocele? Herniation of intracranial structures through a cranial defect due to incomplete closure. There are three varieties. Most cases are occipital in location, and then there is a frontal and a parietal one, and encephaloceles may also occur with genetic conditions. So if there is an encephalocele, we have to look for other parts of the fetal body to rule out any syndrome or any other associated disease. Like for example, McKell-Gruber syndrome, an autosomal recessive disorder characterized by renal cystic dysplasia, encephalocele and polydactyly. So once you see the encephalocele, so you concentrate on these things as well, so that you don't miss McKell-Gruber syndrome. For example, this is a sagittal scan, and at the back of the head, if you see, this is the encephalocele. Similarly, this is a transverse scan, and at the back of the head, this is an encephalocele. And both are very common locations. Axial scan and the sagittal scan, both are visible on these are the occipital ones. So then look for the kidneys. Once you see the encephalocele, look for the kidneys. Look at these. These are two large kidneys. One is here, and the other one is here. Usually at 14 weeks, kidneys are not this size. They are smaller. So these are the large. So we have an encephalocele, and then there are large kidneys. And then look at the hand. At 12 to 14 weeks, look at the hand and count the fingers. This is thumb, 1, 2, 3, 4, 5, and this is the sixth one. And these are 6 fingers. This is polydactyly. So this is a typical case of McKell-Gruber syndrome. In this there is seal, dysplastic kidneys, and polydactyly. 13 to 14 week scan, look for the lemon sign. If you concentrate, this is the front of the head of the fetus. Look at the shape of the entire skull. It somewhat looks like a lemon. So this is a lemon sign, and it is usually associated with ventriculomegaly also. And there is a ventriculomegaly. If you see, the choroid plexus is right about here, and there is convex outward ventricular wall. Once you see the head and you see a different shape of cerebellum is like banana, it is a banana shape, then you look for the spine also. And if there is a meningocele or encephalocele or meningohydrocele, this is a case of Arnold-Chiari syndrome. What is holoprosencephaly? Results from incomplete cleavage of the primitive forebrain. The primitive forebrain, it cleavages and it separates the brain into two halves. If by any reason that is not happening, the two halves are not being formed, and once the two halves are not being formed, it is called holoprosencephaly. And what is there? There is a large ventricle over here. Both the thalami are fused. They are close together and they appear as one mass. And on the sides of these thalami, you see the two choroid plexuses, 1 and 2. These are the two choroid plexuses. So there are various types of holoprosencephaly. So the most lethal one is the monoventricle. Next is the Dandy-Walker complex. It consists of a posterior fossa cyst, partial or complete absence of cerebellar vermis. Some cases also show us hydrocephalus and may be associated with chromosomal abnormalities. This is a dandy walk. What you see is the head of the fetus, and there is a large cyst here. 12 weeks can also give you an indication of cleft lip. If you see here, there are two clefts. One is here, the other is here, and this is the fetal face. This is the upper lip, the entire, and there are two clefts. So the clefts are also can be picked up at 12 weeks, and it can be associated with a syndrome also, and we look for the other thing. So while scanning, any peculiar anomaly, a different or deviation should make you insist on the fetal ultrasound for a longer period and try to find any syndrome associated with it. Fetal nasal bone, usually at a 42 millimeter length crown rump, fetal nasal bone is visible. Its absence or its hypoplasia is associated with a syndrome which is called Down syndrome. And if you look here, these are the two examples. One, there is no nasal bone here, and this, there is a nasal bone, and the scan is done at 12 weeks. And remember, whenever you are doing it, make the slice or your orientation of the probe in a sagittal plane. Make it sagittal, otherwise you will miss the bone. Fetal neck and nuchal translucency screening. What is nuchal translucency? It is fluid collection behind the neck, and usually the normal is between 1.5 to 1 millimeter, but if it increases in its width, it means that there is some abnormality. One should see that it may be associated with a syndrome, and you have to look for it further. And look here, this is a normal nuchal translucency at 12 to 14 weeks. They avoid this. This is the amnion, fluid in the amnion. Actual translucency is this one. Between the two echogenic lines is the amnion. Above it and the fetal tissue is the nuchal translucency. And in this case, at 12 to 14 weeks, it is only 1.5 millimeters. So this is normal. But on the contrary, the next slide is showing you a larger area, which is about here at the back. This is the neck of the fetus. This is increased nuchal translucency. Cystic hygroma. The difference between this is also cystic hygroma is also at the back of the neck. Usually, this is the spine of the fetus, and this is a cystic hygroma. The difference between this and the encephalocele, occipital encephalocele, is that there is a septum between this, usually rising from the center. So these are the two. This is the differentiating point. What we see here is on 13-week scan, there is pleural effusion right about here. This is the left lung, this is the right lung. This is somewhat normal, but the other lung has an echo poor rim around it, which is the pleural effusion, and also see that there is thickness of the which is the edema of the skin. Fetal heart, the best view to do is the 4-chamber view. Otherwise, the fetal sonologists is a different branch. They have different methods to enhance the images of various structures. But the best for a routine sonographer is that you do the 4-chamber view, and what defects you can see. You can see ventricular septal defect. You can see the ectopia cordis, and also the transposition or the isomerism of the heart. And let me show you the examples. Look here, right about here is this is one ventricle, this is the other ventricle, this is the whole heart, and if you see there is a gap between this is the ventricular septal defect, picked up at 12 weeks. And at 14 weeks, if you see, this is the fetal body, this is stomach, and the entire heart is sitting outside the thoracic cavity. Left ventricle, right, and so on and so forth. This is the transposition. Usually aorta is on the left side and IVC is on the right side, but here aorta is on the right side and azygos veins on the left. Another example of dextrocardia, that heart is usually on the left side, but in this, heart is on the right side. Fetal abdominal wall defects. It is done from 8 to 10 weeks, and by 12 weeks the intestine has returned. Usually intestines return back into the at 12 weeks. So this is an example at 10 weeks, physiological herniation. At 10 weeks, if you see at the bottom of the umbilical cord, there is a mass, and this is the physiological fetal intestines. Omphalocele, there is fetus and there is an omphalocele protruding through the anterior abdominal wall. Gastroschisis, bowel loops herniate through an abdominal wall defect, and this is how it looks like. Umbilical cord is way separate and bowel is floating freely in this is called gastroschisis. Another example of gastroschisis, featured urinary tract, usually between 12 to 13 weeks, we see kidneys. These are the two kidneys. We see, and disease of the kidneys can be picked up. This is a multicystic dysplastic kidney. The kidney is increased in size. It is echogenic and there are multiple cysts in it. Megacystitis, usually the urinary bladder is just visible at 12 weeks, but when it enlarges more than 6 millimeters, then it is megacystitis, and there are some associated anomalies with it. We have to look for that. To differentiate between bladder outlet obstruction and syndrome related bladder increase in diameter. Fetal skeleton, 8 to 9 weeks, and then 10 weeks. And what this is a case of short femur. Femur is short as compared to rest of the body. This is a club foot at 14 weeks, abnormal spine, and then the anomaly scan can also give us an indication for multiple gestations, in which this is the dichorionic diamniotic twin peak sign is visible. These are the two twin peaks, the two placentae. Conjoined twins at 12 weeks, this is the thoracopagus. There are three varieties: thoracopagus, omphalopagus, pyopagus, ischio, and cranium. This is the thoracopagus variety. Two separate heads, and they are united at the thorax. Hydatiform mole, already Professor has mentioned about it. No need to go into detail. There are varieties. It on ultrasound is like a snowstorm variance. It can be partial and complete, and it is picked up at 13-week gestation. Third trimester. In third trimester, the monitor. This is basically to monitor the fetal growth, amniotic fluid, biophysical profile, position of the fetus, and assess the placenta. So there are abnormalities in intrauterine growth retardation, abruptio placenta, Spalding sign, and umbilical cord prolapse. Biophysical profile is to see the fetal growth is going on accordingly, and then this is the middle cerebral artery Doppler. If there is growth variation, growth abnormality, then you can also go for Doppler to see whether the brain's perfusion is right or not. This is normal umbilical artery. This can be done in third trimester, and this is a normal. And in here, you see the diastolic flow is absent. This is abnormal. This can be picked up in the third trimester. Fetal presentation, breech, cephalic, footling, etc. This is a frank breech. You see the neck. This is the lower end of the fetus, and this is the presentation. Breech, extended hip and knees, breech presentation. This is a footling. Foot is presenting. This is the umbilical cord which is presenting. Abdominal fetal amniotic fetal index. This is very important for the growth, and we check in the third trimester. Abruptio placenta, you see the placenta, there is retroplacental hematoma. Spalding sign, death of the fetus, crumbling of the cranial bones. So complete anatomic survey is possible in 95% of fetuses at 12 to 13 weeks. Using transabdominal ultrasound in all cases and transvaginal ultrasound. This is important. Transvaginal ultrasound in 20% of cases. The overall detection rate for major fetal anomalies with early pregnancy scanning was 23%. This is according to one of the studies, very famous. Second trimester scanning allowed detection of another additional 33.7%. So this is the justification for doing it not only in the mid-pregnancy, but in all three pregnancies, especially the third one. And therefore, the 18 to 20 week anatomic ultrasound examination still has a major role in prenatal detection of fetal anomalies. So what is the conclusion? Ultrasound performed at 11 to 14 week gestation should be done, but whenever there is a need required or there is a detection at 11 to 14 weeks, the subsequent should also be done. Thank you, and I also thank the researchers who resulted in, I have shared their work in this, and I thank them also, and I thank you for patient listening.